Hi. Today in this talk, I will present you some initial findings of an open trial on Bootcamp for ADHD, a psychoeducation, social support, and engagement group program designed for parents of school-aged children with a relatively new diagnosis of ADHD. Before we proceed, here are some disclosures. This Canada-US collaborative work has been supported by different internal grants from our different institutions. Institut du Savoir Montfort, Division of Developmental and Behavioral Pediatrics at Children's Hospital of Philadelphia, Division of Developmental Medicine at Boston Children's Hospital. Let's start with a little story to put us in context. So here we have a beautiful little family, all smiling. And let's call them the Saunders family. So the Saunders have a young boy that they love very, very much. Since he started school, he became a little bit of a troublemaker. He's never paying attention in class, cannot wait his turn when he needs to ask something to his teacher or when he plays games with the other kids. He gets angry real quick if he doesn't have what he wants right away. All matter for him is now. He doesn't have any friends, well, because the other kids, they don't really like to play with him. And let's not talk about when it's time to do the homework, which is always a real disaster. And now with the pandemic and homeschooling, it became a bit out of control. So Miss and Mr. Saunders decided to seek for help and get an appointment with their family doctor. They meet their doctor. Doctor asks them a lot of questions, make them pass different questionnaires. The doctor makes it clear, Mr. Saunders, your kid has ADHD. ADHD was something the parent already heard of it, but they didn't know much about it. The doctor starts talking about the medication they could start with: stimulant, non-stimulant, amphetamine, methylphenidate, all words that don't say much to the Saunders. Doctor also said that they should seek help from a therapist. Because the Saunders wants what's best for their kid and want to think before making any important decision, they say, well, we will think about it. They go back home and they get even more confused about what treatment choosing for their kid. All neighbor, family, friends, Dr. Google seem to have different answers on what they should do. So what now? How to get out of this giant black hole? As of today, there is two main evidence-based treatment for ADHD: medication and behavioral treatment. Despite that, untreated ADHD can negatively impact many aspects of life. Many families do not receive those treatments. Like all chronic conditions first identified in childhood, parents are responsible to initiate the process of help seeking for ADHD, and they often encounter substantial barriers. Researchers proposed that there were three main barriers making it difficult for families to utilize treatments. First, it's the public health policy, which includes lack of coordination between healthcare providers, public education about mental health, and health insurance policies. The second one is the accessibility, which includes the cost of services, access to services depending on the region, city, and community, and the transportation. The last one, the belief and concern barrier. More precisely, the belief and concern barriers include stigma, defined by parent perception and internalization of stigma, which is when the parent of a child with mental illness feels ashamed, blame themselves, and avoid social contact. Attitude towards treatment, which is the belief about the etiology of the disorder and concern associated with the diagnosis, as well as parents' ambivalence about using medication or behavioral intervention to treat the condition because of the possibility of side effects. Last one, parent empowerment regarding services, which stands for the perception and attitude parents have about their roles and responsibility within their local service systems and their ability to advocate on the behalf of their kid. Clinicians believe that the belief concern barriers may be amenable to change with clinical care. Many researchers have highlighted the importance of family engagement in the treatment of ADHD and the need for it to be a research priority. The existing approaches on family engagement, they do not address the fundamental problem of engaging families before treatment begins. Basically, parents need to already use one treatment to get involved in one of those family engagement programs. To the best of their knowledge, engagement efforts generally have not focused on promoting family involvement in a comprehensive multimodal care, requiring that parents be able to access and obtain needed services from school, health, and mental health providers. So here we are now with Bootcamp for ADHD, who was created to fulfill that need in the system and create a bridge between the moment of the child ADHD diagnosis and the initiation of treatments. Bootcamp for ADHD is there to help parents get all the information and help they need to make the best choices and decisions according to their preference for their kid. Bootcamp for ADHD is a brief engagement program developed at the Children's Hospital of Philadelphia in 2010. It is commonly administered to groups of 6 to 8 families and target parents of children with a relatively new diagnosis of ADHD age from 5 to 11. It is designed to provide family with psychoeducation about ADHD and its effective treatments, to help families gain support from each other, to promote parental empowerment to navigate the health and educational systems, and to support parents in learning organizational strategies to develop a comprehensive plan for their children. More specifically, the first session focused on helping parents understand the diagnosis of ADHD, its developmental course and common comorbidities. The second session focuses on helping parents understand and connect with each other about the challenges ADHD brings home and giving parents a preview of behavioral parent training. Third session focuses on helping parents understand the neurodevelopmental basis of ADHD and the pros and cons of medication. And the fourth session focuses on the impact of ADHD at school and how parents can build a positive partnerships with teachers and increase their child's success at school. The program has 5 main components. First one, education for parents. Clinicians share information based on science and use a plain language to make the information accessible to all parents. Second one, behavior therapy preview. Clinicians give a preview to parents of what looks like a behavior therapy and what it implies. The third one, motivational counseling, which aims to engage parents in their kids' treatment while always respecting their choices and preference toward treatment. The programs support the idea that parents are the one who knows what's best for their kid. Clinicians are there to answer their concerns, validating their emotions, feelings, and encourage all the little changes and efforts that parents do daily for their kids. The fourth one is the group therapy, which aims to reduce isolation, create network among parents that can discuss together and feel connected with the similarities they all share. Last one, support for implementation at home relate to the different homeworks, materials, tools provided by clinicians to help parents apply different techniques at home. So clinicians believe that under those program components, this could result in an increase of parents' feeling of empowerment towards their child's treatments and a diminution in stigma parents go through and all the guilt and negative emotions, and also treatment acceptability as parents are more informed about them. Those outcomes on belief attitude barriers will then affect treatment utilization with parents intending to start a treatment based on science and later on the initiation of those treatments. So the program trial I'm going to present you today was conducted in 2018-2019 at Montfort Hospital in Ottawa. The goal was to assess the feasibility, acceptability, and preliminary efficiency of BC-ADHD at a different location than the original one, and if the positive outcomes they had in Philadelphia could be replicated in Ottawa. Participants were 59 parents of children with ADHD aged between 5 to 11 years old. They were separated in 9 groups, and the program was delivered in person. 6 groups were French and 3 English. Parents doing the program were mostly full-time working and highly educated biological mothers. Their children were mostly white boys who had French as first language, and a quarter of them had a learning disability and some others comorbidities such as oppositional deviant disorder and anxiety. Before starting the program, 57% of families were already on medication, whereas only 4% were engaged in behavioral treatment. Let's now look at the results of the study. So first question of the clinicians that they asked after the program was delivered was, is the program feasible in a different location? So that's the thing. Maybe some of you will think, well, obviously it's going to work in Ottawa if it worked in Philadelphia. Well, in science, to prove that a treatment works and to be able to make conclusions about it and say, yes, trust us parents, this is going to work, it's not that simple. To have solid proof on the efficiency of a treatment, we need to do multiple trials within different populations. So that's why scientific results takes way more time to be spread out than some advice we can find on internet. So back to your question, is the program feasible? To answer this, researchers look at first, how was the attendance? Were parents satisfied? How much did they like the program? So let's see the result they had. The results suggest that BC-ADHD in terms of parent attendance with a mean of 96% over the course of the program. Also, homework completion was high with a mean of 78% across the homework given. And so both parent attendance and homework completion exceeded the minimal threshold expected. The results also suggest that parents were really satisfied. For the weekly satisfaction measure on a scale of 1 to 7, the mean satisfaction was 6. After the program, parents were asked to rate their satisfaction over the component of the program, which included the program organization, information provided, opportunity to share with other parents, handouts, and homework. Again, parents were very satisfied with a rate of satisfaction that varied between 6 and 6.5. In terms of program fidelity evaluation, which refers on how accurate the interventions were provided based on the theory of the program and the interventions related to it, which was given in a manual. 5 dimensions judged to be important in BC-ADHD were measured, as shown here. So encouraging parents' engagement in the treatment of their child, eliciting change talk, providing emotional validation, building parental connections, keeping parents focused on scientific information. So each components were scored on a scale from 1 to 4 with a mean of 3.7 out of 4, which shows that overall the program fidelity was very good. So second question was, based on the program's theory, did BC-ADHD brought changes into belief concept barriers, as well as their utilization in treatments based on science? So in other words, were parents able to fly over the black hole of misleading information created in the gap between the moment of the diagnosis and the initiation of treatment? So the results suggest that participation in BC-ADHD leads to a small increase in parent empowerment regarding child services. So even if it's a brief program and a small changes, the results suggest that it still had an impact. Here we have the results for the Stigma. And the findings suggest once again that participation in bootcamp for ADHD led to a small reduction for it too. Also, BC-ADHD appears to lead to a small reduction in parent concerns regarding medication side effects at both post-treatment and the 6-month follow-up. So this one is really important because parents have a lot of concerns about medication. So the risk of side effects or that their kids might become addicted to the medication. Basically, parents are focusing more on what can go wrong instead of what can go right. And BC-ADHD seems to have helped with that. For the adverse effects about behavior therapy, BC-ADHD helps to decrease the concerns parents may have for that. Although, when we look at the concerns about the feasibility of the behavioral treatment, BC-ADHD to a small reduction at post-treatment, it was not maintained 6 months after. So also we remember that at baseline, only 4% of the families were having a behavior therapy for treatment for ADHD. So it really highlights the problems we have in our systems to access to mental health services that don't imply medication. For the results about treatment utilization, BC-ADHD appears to lead increases in the actual use of medication and behavioral treatment from baseline to the 6-month follow-up. More specifically, there was a 15% increase in the medication treatment among children who never had started it before. This gives hope that BC-ADHD might help parents giving a chance to medication and the positive outcomes it can provide to their child. As we see on the other graphic, there was an important increase of 63% for the behavior therapy treatment utilization. Among this number, about 75% of parents receive group behavioral parents training at Montfort Hospital, about 50% receive family behavior therapy in the community, and about 10% receive behavioral peer interventions. Overall, the results suggest that BC-ADHD is a promising brief engagement program that appears feasible, acceptable, and potentially useful at preparing and engaging parents in multimodal care for children with ADHD. However, some limitation must be considered. The sample is very homogeneous, white educated, mainly the mothers, their child was a boy. Also, 57% of the sample was already on medication at baseline, which may have influenced the result and the real efficiency of the program. Also, the results were given by unblinded informants. So what does that mean? Is that the clinician that believe in the program and also the parents who want the program to work are not the best judges to measure objectively the efficiency of a program. Future work will ideally need to include more objective blind outcome measures. And last one, so BC-ADHD is a clinic program, so its target is not aiming on health policies and services accessibility. And clinicians should find a way to address this, as we know it is a major aspect in mental health accessibility. Now, you might wonder, so where can I have access to the program? Well, the intervention is still considered experimental, so it is not currently available in the community, except at Montfort Hospital, Children's Hospital of Philadelphia, and Boston Children's Hospital. Obviously, the goal is to make the program available in the community within a couple years. Currently, there are different studies in progress at the Children's Hospital of Philadelphia, and in 2020, there was a study published about implementing the program in an online setting in which Dr. Sébastien Normand, the one who conducted the studies I've presented you today, has been working on. So now, the future directions of Bootcamp for ADHD include to pursue funding to test larger group, looking at demographic and clinical predictors of outcomes to better know which population will benefit the program the most, For example, would there be a difference between the degree of symptom severity, or if the kids are already receiving a treatment or not, if parents have ADHD symptoms, or will having both parents at the program would be more effective? Still so many questions and possibility we can ask. Clinicians also want to pursue funding to look at implementation in diverse settings, such as primary care services, online services, and in diverse populations, such as ethnic minority group and low-income population. They also want to find a way to adapt the program for teenagers. The most recent guidelines for treatment and evaluation of ADHD recommend to develop methods to involve parents and youth in their home care and improve adherence to both psychosocial and medication treatment. In this sense, it's clear that Bootcamp for ADHD could potentially bring important positive outcomes in ADHD treatment to help empower parents and make ADHD treatment more accessible for children so they can receive the treatment and care they need to develop their full potential. Before ending this presentation, I want to thank our institutions and all families, clinicians, and students who made this study possible. I want to thank also the Interdisciplinary Family Center of Eastern Ontario and Dr. Marie-Pierre Vendette to make this presentation possible and make accessible research and science to families. If you want to have more information about the different outgoing or published studies on ADHD from our research unit, directed by Dr. Sébastien Normand, and if you would like to be part of the studies or know someone who might be interested, go to pris.uco.ca. Just on the screen, you can see the full address so you can go there and have more information about it. And also on the website, you can also have access to different useful resources. So thank you.